Pleasure today that I get to introduce our speaker. But before I do that, let me just draw your attention to some future talks coming up on March 21st. That is tomorrow, Thursday. That's Thursday, it's the 19th. So not the 20th, but the 21st, Thursday. We have Developing Multi-Level Change Capacity, Leveraging Physician Vanguards in Medical Home Transformation by George Potworowski. Sorry if I messed that up. He's not here. And then on April 24th, we have, I think it's April 24th, 2019, we have Interdisciplinary Approaches to Physical Activity, Built Environment Research and Translation to Policy by Jim Salas. But today we are very lucky to have an old friend of mine, Tanner Caverly, here to visit. He is now at the University of Michigan as an assistant professor. He trained here in internal medicine and trained under Allie Kemp in her research fellowship, in the primary care research fellowship. We did everything we could to keep him here, but his family, including offering him a job, but his family pulled him back to the Midwest in Michigan, which we understood. I get to meet up with Tanner every year at the Society of Medical Decision Making. We usually walk around the town we're in and have a drink and catch up and debate things. He's probably going to say some controversial things. When he was here, he would say controversial things. And that's a good thing because he'll get us to think. And I hope today's talk will be appropriately controversial. But anyway, with that, I will turn it over to Tanner and let him go from there. Where should I put this? Let's see if I can. I'll just do it.
What do you think? All right, so I'm really excited to be here and see some familiar faces, and really excited to talk about this. It seems like, and I guess it's not surprising since I trained here, that my work is very appropriate for this seminar series, and so I'm excited to talk about it and get some feedback from you all. All right. So when you think of a typical clinic visit currently, this is the image that I think should come to your mind. This is the image of modern medicine. This is a typical jeepney ride in the Philippines. We have a member of our research staff who spent a lot of time in the Philippines, and he's educated us that the jeepney is the most common form of public transportation in the Philippines. And apparently it's very common for it to be so crowded that people are just hanging out the sides. And apparently there's occasionally even some various forms of livestock also on the jeepney. So this is what a typical clinic visit looks like. And all the passengers are everything we're trying to cram into a clinic visit. I'm really excited particularly to give this talk here because I know a lot of folks here have done a lot of good work about how to deal with these challenges, these competing demands in primary care specifically. But this applies to all kinds of specialties in any type of clinical setting. So, you know, if you spend any time in primary care or in a clinic setting, you'll notice that clinicians are juggling a large number of competing demands. And it's going to look different in nephrology and cardiology. But this is how those competing demands look in primary care. Hopefully the patient's concerns are in the driver's seat. If the patient's sick, we're addressing those concerns. And then there's important tasks, reviewing their medications. And in primary care, there's a long list of what I'm calling routine tasks. And these are tasks that are more population driven, and they're routine from the standpoint of, you know, they're very important, but they're things that we constantly have to think about checking off. So these are things like screening and counseling for alcohol, tobacco, diet, depression, suicide, domestic violence, on, and the list is quite long and it's growing. And these can all be quite important for our population. But then on top of all that are these decisions that I'm very interested in, which are what we're calling our team substantive everyday decisions. And these are decisions that really benefit from more personalization to the individual patient. So these are decisions like when to start or stop a statin medication, an aspirin, blood pressure medications, various forms of cancer screening fit into this category. Lots of other preventive services fit into this category. And we have a lot of decisions to make about these decisions, including for whom should we offer these services to, how frequently should we do this, all of these things build up. And a lot of our chronic disease management takes place here as well. Today, I'm going to talk about one particular good example of this type of decision, this class of decisions that we're calling substantive everyday decisions. And I'm going to talk about lung cancer screening as a really good example to think about how we can personalize these decisions given everything that we have to do in a clinic setting. So lung cancer screening is a good example because, like a lot of these decisions, it occurs very frequently, almost on a daily basis, perhaps multiple times for the same patient in a clinic visit. These aren't major decisions like putting in an LVAD or doing a major surgery, but they do have important consequences for patients. For instance, asking a patient to get lung cancer screening every year for the foreseeable future, with pros and cons as well that are important. And personalizing these decisions can add a lot of value to our care. But they pop up so frequently in clinical practice, particularly in primary care, that time for personalizing those decisions and enhancing that value is really scarce for these types of decisions. Time is actually more scarce than even I realized. So we recently did a study where we found that among 1,000 different clinicians, these were PCPs, primary care providers in this case, with different types of work habits, taking care of a US representative patient panel, so kind of a typical patient panel. None of the providers could come close to discussing all of the highly recommended preventive services that their patients were eligible for. And these are all the US Preventive Services Task Force Grade A, B, and C recommendations. So it's really a subset of the type of decisions I'm talking about. And they couldn't even come close. And that really applied even to the PCPs in our sample that worked very long hours and had a very small patient panel. It was kind of off base. And we also found that clinicians typically have on average about 20 minutes to do this type of counseling during a typical working day, whereas it takes about over 6 hours to actually complete it if you're asking them to complete full shared decision making for these types of decisions. So on average, clinicians fall about 5.6 hours behind every working day. Obviously, that's not sustainable if we're asking them to complete full traditional shared decision making for this type of decision I'm talking about, like lung cancer screening. And in fact, we thought that this I accidentally clicked this one up here. Uh-oh. One false click. Oh. There it is. All right. So we actually felt that it was so comically off base to expect clinicians for these types of decisions to complete full shared decision making as we traditionally conceive it, that we actually wrote it up as a satire, and we published it in the most recent BMJ Christmas issue. And the nice thing about the Christmas issue is it allows you to combine rigorous real research, and this was real research. This wasn't a joke. These were real findings. But we had a very satirical interpretation, so it allowed us to make our points very strongly, and it was a lot of fun. I did it again. All right. But our team at the Ann Arbor VA and the University of Michigan is very interested in trying to tackle this issue of how to improve and personalize decisions in the face of all these competing demands. And we spent the last several years trying to help primary care teams incorporate shared decision-making and counseling about lung cancer screening for their patients. How do we do a better job personalizing those decisions and selecting the right patients? And the current model for personalizing decisions like lung cancer screening is shared decision-making. And we're calling the traditional model of shared decision-making full shared decision-making. And because of the work we've done and because of the experiences we've had trying to implement this for lung cancer screening, most of our team has come to view full shared decision-making for lung cancer screening as akin to trying to put a big bull with big old horns on top of this bus that's already packed full. In other words, we don't think it's very feasible, but we do think that we have options for more feasible approaches that can move the ball forward. And so that's what I want to talk about today. I want to talk about lung cancer screening in particular, but I want to talk about it as a model for how we can study personalized decision-making in clinical practice, and as a good example for this class of decisions that are substantive everyday decisions that occur very frequently in clinical practice. I'm going to tell you about 3 things that we think can enhance clinicians' capacity to personalize these types of decisions. First, they need easy access to individualized estimates of benefit for their patients. Second, they need to understand the likely bounds on the preference-sensitive zone, and I'll describe what that means. And third, they need a patient-centered, feasible process that works in routine practice, something that's more feasible than what we have currently. And we're calling it targeted brief shared decision-making. And this can be a contentious area, and I want to talk about some caveats also to our approach that you'll hear. So first, lung cancer screening is a really good example. It's a really good model for how to think about these issues that come up frequently. And that's for a number of reasons. First, there's strong evidence that lung cancer screening can reduce the risk of total mortality. It can reduce total mortality for eligible patients, which is really unique in the context of cancer screening, where typically we see that it reduces cancer-specific mortality. This actually has a stronger benefit and reduces all-cause mortality. But that mortality benefit varies hugely across the eligible population, from a pretty small benefit for some eligible patients to a quite robust benefit for ideal candidates for lung cancer screening. There are important consequences. There are important cons with lung cancer screening, such as false positives that can lead to risky biopsies, and those can have complications. It can be expensive. And because of these trade-offs, all the current guidelines that I'm aware of request shared decision-making for this type of decision for lung cancer screening, and Medicare actually requires it for its population of patients for payment, which is a unique among really preventive services and medicine in general at this point. So perhaps because of those trade-offs and the complexities of lung cancer screening being recognized, uptake of lung cancer screening is extremely limited so far. It's a relatively new service, but we've had it around since 2011. We've had good quality data that it can be helpful for patients. Only about 2% of eligible patients were screened in 2016, and you're eligible if you're between the ages of 55 and 80. If you smoked, if you're heavy smokers, this isn't just for people that have smoked a few cigarettes. These are for very heavy smokers who've smoked greater than 30 pack years. They're either a current or smoker, or they're a former smoker that have quit recently within the past 15 years. And they're healthy enough to get a curative lung resection should you detect a lung cancer early. But despite that low uptake, there really is a good population rationale for lung cancer screening. It's the most deadly solid tumor by far in the US. In 2017, about 160,000 people died from lung cancer, which that number is a lot more than colon, prostate, breast, and melanoma cancers combined, the number of people that died from those. So there's a huge morbidity and mortality from lung cancer, and all of that is concentrated on a relatively small, easily identifiable group, which is heavy smokers. And heavy smokers, more and more as time goes on, represent also a pretty vulnerable population with lower education, lower income, and higher rates of mental illness as well. So, you know, there's growing evidence, strong evidence, that screening can help some patients a great deal. And last summer, we published a study in Annals of Internal Medicine where we tried to put a lot of these pieces of the puzzle together, you know, the important clinical outcomes, the benefits and harms, along with patient preferences. And it was a microsimulation-based study. And one of the main findings was that among the group of patients that had a pretty good life expectancy, so at least 10 years of life expectancy, as their lung cancer risk went up, which is basically a function mostly of age and how heavily they've smoked and how long. But as that baseline lung cancer went up, the benefit of lung cancer screening started to be quite robust, as long as their life expectancy was also pretty good. In fact, we found that for ideal candidates with good life expectancy and very high risk for lung cancer, the benefit of lung cancer screening is much, much larger than mammography, and really compares also quite favorably to that of colon cancer screening, which is something we do routinely for our patient population. We've been trying to take those findings to the point of care in with the use of web tools that we've developed and refined over the past several years for lung cancer screening, and we're currently studying how to personalize lung cancer screening discussions using these tools with screening coordinators and primary care teams. We're studying it at 8 VA sites across the nation. And we're really focusing on these two aspects of our decision-making model. We're trying to provide to the point of care individualized estimates of benefit so PCPs have access to that. and then also an idea about where the preference-sensitive zone for lung cancer screening is so they can tailor their approach based on that, and you'll understand that in a little bit. I didn't want to, in this talk about our specific tools in that specific study. I did want to talk about our overall decision-making model for these types of decisions like lung cancer screening, and why we think it can really enhance clinicians' ability to personalize decisions like this. I'm going to go through the different elements. But the overall premise for our approach to making these decisions more feasible, it's based on the following premise. We believe that clinicians could really use a practical approach that enhances their capacity to be skilled health advocates for their patients and strong supporters of patient autonomy. Okay? And this is important because above all else, patients want competence from their clinician. Okay? And in clinical practice, in primary care in particular, I really think this is the sine qua non of competence is probably the ability to find and move directly toward the most important medical issues for our patients. What's the most important issue for you right now? And I want to address that first and go from there. But at the same time, most patients are extremely uninterested in being told what to do, particularly with these types of decisions. So what we need is we need to enhance clinicians' capacity to be skilled health advocates. And by skilled, I mean nuanced in our approach, sophisticated in our approach, so we're not just telling patients what to do, we're a little bit more subtle than that. Okay. And I think a good analogy or metaphor for this idea that we want clinicians, we want to give them the tools to be skilled health advocates for their patients is the goshawk. And the goshawk is a species of hawk that's found all over North America. It's found all over the world, really. And I got this idea from a book called H is for Hawk. I don't know if any of you have read it, but it's a wonderful book written by Helen McDonald, and it teaches you all about the goshawk. It's about her experience training a goshawk in the year after her father passed away. And it's an interesting book for a lot of reasons. But I learned a lot about the goshawk. And the Latin scientific name is Accipiter gentilis. Accipiter is Latin for to grasp, and gentilis is Latin for noble, in the sense of being genteel, refined, worldly wise, and sophisticated. So Accipiter gentilis is the noble grasper. And I think that's a good metaphor for what we think a good clinician should be. They should quickly grasp onto what's most valuable for their patients, but they should be noble, refined, and sophisticated in the way they're doing that. So we're not just telling patients what to do all the time. All right. In the context of our overall approach, we think that you need these first two things, individualized estimates of benefit, and some clarity about where the preference-sensitive zone is for that service, to see like a goshawk, to be a skilled health advocate and grasp on what's valuable for that patient at that time. And you need the third thing, a patient-centered feasible process, to be elegant and refined like a goshawk. So you're not just telling patients what to do. Be a skilled communicator. All right, so what do these things mean? And I'm going to talk about them in the context of the goshawk. So goshawks have really good visual acuity. That's kind of what they do. They have the visual acuity to find and the instincts to move directly toward the most valuable targets in their environment. So they can resolve a tiny 2-millimeter insect from greater than 30 yards away, like an ant. They can see, they have a really fast visual and sensory system, so they can actually see the individual wing beats of a bumblebee as it flies by. And they're really opportunistic. So they can see all of these things in their environment, and they have the instincts to move toward the thing that's going to be most valuable. They have the instincts to avoid that ant and move to the valuable pigeon for their survival. And this is what I think a good clinician should be able to do, but it's really tough. So what's the most valuable thing for my patient right now? And there's going to be a number of actions in primary care that you could do for this patient, but what's the most valuable thing and what's the next most valuable thing, and what's not so valuable? This can be very counterintuitive and difficult to tease out. What we'd ideally like to do is to give clinicians tools so they can more easily identify what's going to be very valuable for their patient. In the context of this particular patient, I put lung cancer screening as the most valuable because that's what I'm working on. And I put the ant as starting aspirin for no particular reason, but let's say this patient has a very high bleeding risk and it wouldn't be a good idea to start aspirin. So how do we help clinicians understand, tell the difference between the ants that they should avoid and the pigeons that they should pounce on for their patient? Well, we think that giving clinicians individualized estimates of benefit can help them see like a goshawk. So they can see what's valuable based on these individualized estimates. And the reason that these individualized estimates are so important is for services, substantive everyday decisions like lung cancer screening, the benefit, like I said, can range to a huge extent. And some eligible patients have a very small benefit, other patients have a very large benefit. So we need to give clinicians the ability to see who has small benefit and who has large benefits. And we can only do that if they have individualized estimates. And without these, they really can't be good health advocates for their individual patients. The best we can do is kind of average information, one-size-fits-all type approaches, which doesn't go far enough to personalizing these decisions. And really, if we don't have these, we can't really engage, we can't really be health advocates for our patients. We can't really engage in high-quality shared decision-making at all. Fortunately, obtaining evidence of individualized benefit, absolute risk reduction for our patients is actually quite feasible. It's really just a combination of understanding what their starting risk is for the disease outcome, and then multiplying that by the relative risk reduction with the screening or treatment. And for these types of decisions I'm talking about, these everyday decisions, we often have very good estimates of relative risk reduction from clinical trials. So in the context of lung cancer screening, we have the National Lung Screening Trial, which was a landmark study published in 2011 that showed that lung cancer screening every year with a low-dose CT scan can reduce lung cancer mortality by 20% relative risk reduction. And that's typical for a lot of these decisions, pretty high-quality evidence for the relative risk reduction. And we can get estimates of the starting or baseline risk for the disease outcome. For lung cancer screening, this would be lung cancer risk at baseline, and that would be a function of their age and smoking history and family history and a couple of other factors. But you get estimates of that from validated prediction models that often exist for these types of decisions. In the context of lung cancer screening, we have 4 very good models that can accurately predict lung cancer risk for our patients across different race and ethnicity groups. So actually obtaining individualized estimates of absolute risk reduction is actually quite feasible, even though it's not typically brought to the point of care in a consistent fashion. It's not routine practice yet. But even if we have those individualized estimates to help us to start to tell the difference between ants and pigeons, we still need the bounds in the preference-sensitive zone to really see like a goshawk and really quickly grasp onto what's going to be most valuable for our patients. Let me tell you why that's the case. So coming back to the goshawk, goshawks have a really different visual experience than we do. Helen McDonald in her book kind of describes it as something like the difference between seeing in color and seeing in black and white. And that's because goshawks can see polarized light. They have little proteins in their eyes where they can see the electromagnetic fields of the earth. They can see thermals rising into the air and spilling over into clouds. They can even see ultraviolet light. So while we can see color in 3 dimensions, they can see color in 4 dimensions. And that must be an extremely different visual experience, and probably the best we're going to do in terms of thinking about what that must be like is McDonald's point that maybe it's something like seeing in black and white versus seeing in color. We see in black and white and the goshawk sees in color. So how can we see like a goshawk in the context of making better decisions? We obviously don't need to see ultraviolet light. We don't need to see 2-millimeter insects, but we really think that clinicians can use the clarity around the bounds on the preference-sensitive zone to see like a goshawk. Let me tell you why that's the case and what I mean by that. Decisions in clinical practice are usually dichotomous. They're usually discrete. We either decide ultimately to treat or to not treat, screen or to not screen. And that's a reality. But underneath that reality is also another layer of reality, which is that for these types of decisions, for most decisions we make in clinical practice, the underlying probabilities of benefit and harm for our patients are continuous. They exist on a spectrum. And they result in a spectrum of benefit for our patient, from a chance of benefiting that can be very small, less than 0.05%, to a chance of benefiting that can be as large as over 50% chance of benefiting. So to pretend in the world that the world of recommendations is black and white, that the difference, to distinguish between recommending against a service and recommending for a service, all you need is this tiny, thin, bright line to say, Okay, just to the left of this line, that's a terrible idea. You shouldn't be screened. You shouldn't be treated. Oh, but over here, to the right of the line, that's a great idea. We're going to have insurance cover that for you. Great idea. We think that that model that we currently have to create this dichotomous screen, don't screen, is actually, in the face of this continuous chance of benefiting, quite illogical and perhaps even disingenuous. When we talk to clinicians and when we talk to most patients, they readily accept that the world of recommendations isn't black and white at all. They readily accept that it's probably a little bit more colorful than that because of the uncertainties that we have. They easily accept that there's probably a zone that's a yellow or a gray zone in between recommending against and recommending for treatment or screening, and that that zone exists because there's always going to be some level of uncertainty about the benefits and harms, and there's always going to be at least moderate differences in preferences about those benefits and harms from our patients, particularly when those benefits and harms are in a little bit more fine balance. And because of that fact, we think that guidelines and clinicians should be really clear in their heads and in the guidelines, ideally, about 3 different zones of benefit. So we have the green zone, where the benefit is so large that there's general consensus that it's going to clearly outweigh the downsides. These are the valuable pigeons that we should pounce on, maybe like lung cancer screening for an ideal candidate. Then there's the red zone on the other side, where the benefits are so small that the harms are really going to be dominant. These are the ants that we should avoid, maybe like aspirin for primary prevention in someone that has a very high risk of bleeding. And then everything else in between is the yellow zone. And the yellow zone is where the net benefit is a little bit more uncertain because of the pros and cons, and really are going to depend, because of that uncertainty, more on the patient's context and their particular preferences and how they weigh that. In most cases, given the inherent uncertainties in clinical practice, we think that yellow zone is going to be quite wide for most clinical services, and it's particularly true for lung cancer screening. We think this is really important to see like a goshawk, to see in color. We think that's really important because if clinicians don't see that way, if they don't have access to individualized estimates of benefit, if they're not clear about where that preference-sensitive zone is, then this is the color that you get. You get one-size-fits-all recommendation, and this is what it looks like when you mix equal parts red, yellow, and green. And it's kind of an ugly color, and I think you'll agree. It's not pretty. Fortunately, we don't have to live in that ugly world. If we can provide clinicians individualized estimates of benefit so they can locate where on this spectrum the patient is in front of them, it can vary hugely. And if they're clear about the likely preference-sensitive zone, they'll be able to quickly grasp onto what's valuable for their patients and distinguish the ants from the pigeons. And this is what our team is doing with lung cancer screening, trying to bring this information to the point of care. But even if we do that, we found that even if we bring that information routinely to the point of care, it's not easy at all in the face of all these competing demands to put that information to clinical use, to put it to practical use. So we still need a feasible approach to kind of put that information to use. Clinicians need an efficient process for engaging in these decisions because time is so limited. And if it's not a very efficient process, they're going to fall very, very far behind each working day. We've already showed that. And they need a way to make these decisions like lung cancer screening more patient-centered. We've seen, and we feel very strongly, that current proposals that promote full shared decision-making for these types of decisions that occur every day in clinical practice is just not feasible. It's not realistic. And that we continue to think that progress is unlikely until we have a more feasible alternative to full shared decision-making as it's traditionally conceived. Because without a feasible alternative, we've seen that over and over again, clinicians are going to revert to an approach that's not really personalized at all, such as this conversation from a recent JAMA Internal Medicine study where they looked at how different conversations are going for lung cancer screening, where there's actually a requirement for robust shared decision-making. So the physician says, because of the smoking history, I'd like to get a CT scan of the lungs and make sure there's nothing in there. This is a new benefit now. Insurance companies are paying for it. Patient says, okay. Physician seems a little surprised to be so quick and happy that they can move on. Now I'll just get that set up and we'll move on. So you do get a sense of the time pressures in clinical practice, but you can also see how this is kind of one size fits all, not an ideal decision-making process, but it's challenging to do better. So I want to talk about our proposal, which we're calling targeted brief shared decision-making, that we know is feasible because of the providers, the physicians in our group carry out this approach daily for these types of decisions, and it does work pretty well from a feasibility standpoint. And we believe that not only is it feasible, it can help clinicians communicate in a more refined way so they can be skilled health communicators so they're not just telling patients what to do. All right, rather than tell you what the approach is, I thought it'd be much more interesting to tell you what it sounds like. And because language and tone with these sorts of things is very important. So this comes from one of the more skilled primary care physicians that I know, my mentor, Rod Hayward. I just went into his office and I said, can you talk about a patient smack dab in the yellow zone? So this is totally unscripted, but this is the kind of what it would sound like coming from an expert who's thought a lot about these things.
I wanted to talk to you about lung cancer screening. You are a candidate for it, but for you it's a tough decision, right? There's some pros and cons. If you're the type of person who would have a lot of regret you missed a lung cancer that could have been caught early and cured, that's a reasonable decision to get it. If you're the type of person who says, I only want to undergo cancer screening for CT scan and risk of false positives and follow-up biopsies, unless there's a lot of benefit, it would be reasonable for you not to get it. The good news is you're not at super high risk. So, it's a little bit of benefit, a little bit of downside, and it's really a personal choice between how you feel about getting annual CT scans versus the risk of false positives and unnecessary findings.
All right, so that's what it might sound like. That was unscripted. He probably could tighten that up a little bit, but that's what it's going to sound like in clinical practice. And that's just the reality of the conversational approach that we take with patients. So this is the structure of what you were hearing there. And this is kind of the approach that we've developed and refined over the past several years. First, make a personalized recommendation for that patient based on where they are in the spectrum. That recommendation strength varies based on the degree of benefit and the evidence for that benefit. We want to be encouraging high benefit care for our patients, so we continue to be health advocates for them. We want to be discouraging, clearly, riskier trivial care. And we want to acknowledge that there can be patients in this preference-sensitive zone that's very going to exist most of the time. We want to inform them that the decision is preference-sensitive, and we want to inform them about the key factors in the decision and how that can affect the decision that they make. And then the second piece of this is that we want to fully respect their patient autonomy. It's hard to incorporate this aspect into the audio clips because it depends on how you respond to the patient, which is a very important aspect of this. But we want to be respecting patient requests specifically for more information, and we want to be respecting any disagreement they have with our initial guidance. That means that on request, we're ensuring access to high quality quantitative information for patients that want that kind of information, and we're fully supporting their veto power to distinguish between the recommendation that we're making and the decision that they make. Those are two different things. So in the context of the audio clip that I played you, first thing I'll point out is it did take 1 minute and 7 seconds. It's a little bit longer for the preference sensitive zone. There's a little bit more to discuss, but it's still pretty succinct, and it's not going to, with this approach, one of the nice things is it's quicker, and it has to be quick to be able to be feasible in primary care. First, make a personalized recommendation. The recommendation here was quite weak. He said, basically, you're a candidate. And then you want to inform, if the patient is in the preference sensitive zone, like this patient was, you want to inform them that the decision was preference sensitive. So he said things like, for you, it's a tough decision. There's a little bit of benefit with a little downside. And then he briefly presented qualitative information about the most important factors affecting the decision for this patient. And he did it in a format that works really well, and it's pretty efficient. He said, if you're the type of person that would feel this way, it makes sense to get screened. If you're the type of person that would feel that way, it makes sense not to screen. So in this preference sensitive zone, he's really giving two recommendations. And it really recognizes the fact and explicitly acknowledges the fact that this is a tough decision. There may be no right answer, but it doesn't fall into the trap of being wishy-washy, so patients don't know what to do. They have something to hold on to when you talk about it that way. And then he explicitly stated that there is a choice to be made and gave the permission to make the choice based on what was most important to them. So he said it's really a personal choice between the small chance of catching a lung cancer early and the risk of false positives and unnecessary biopsies. Those are the key factors in this decision. All right, so here's what it sounds like for a person that has a lot more to gain, is moving out of the preference sensitive zone. So it's going to sound different for this patient.
I wanted to talk to you about lung cancer screening, and I think it's a good idea. That the benefits are fairly high, but there are some downsides in that we can find false positives, little dots on the CT scan that end up not being cancer, and I'm, getting biopsies. But in your case, I think that is worth it because your lungs are still in pretty good shape. Your risk of lung cancer is pretty high. And so overall, I'd recommend it. What are your thoughts about that?
All right, that sounds different. So this patient has a lot more to gain with lung cancer screening. They're outside the preference sensitive zone, which means that the benefits are getting so large that even patients with negative preferences tend to, the benefits kind of outweigh that, at least in terms of the initial recommendation we're making, which is different than the final decision. Took 40 seconds. The personalized recommendation was stronger here for this patient because the benefits are much larger. That I think it's a good idea for you. Overall, I'd recommend it. In terms of talking about the benefits, that language was also stronger. Benefits are fairly high, but there are some downsides. I think it's worth it. Your risk of lung cancer is pretty high. And then at the end, in terms of throwing it back to the patient, he said, what are your thoughts about that? So explicitly bringing the patient in at the end of the conversation to start that conversation. And in my clinical experience, that conversation is fairly quick. Patients can make these decisions fairly rapidly after a discussion like that, most of the time. Sometimes they want more information, and we have to be able to have the resources to get that information to those patients. All right. And here is what the conversation might sound like for a patient that has a very high benefit. And this is an ideal candidate for lung cancer screening where the benefits are one of the larger things we do in the context of preventive medicine.
One other thing, I would recommend that you get lung cancer. The reason is that you have smoked a lot of cigarettes for a lot of years, but your lungs are still okay, and catching the lung cancer early could save your life. You're like an ideal candidate. And unless you have strong objections to getting a CT scan annually, I would recommend it. I would also recommend that you stop smoking. And if you stop smoking and do it, it will greatly improve your life expectancy and decrease your risk of cancer.
All right, so that was a much stronger recommendation, as you could hear. He said just very clearly, I would recommend lung cancer screening for you. It took 43 seconds. He said things like you're an ideal candidate. It's going to it can greatly improve your life expectancy. And then in terms of respecting autonomy, it's a little bit nuanced here in this conversation, but he did say, unless you have strong objections. And there is a distinction between making a recommendation, which is kind of out here on the table. Here's my recommendation for you. I'm telling you what it's based on. It's based on the fact that you have a lot to gain. But there are objections, and you can make objections. And I want you to make objections if you feel strongly. But I want you to feel strongly because I'm telling you that the benefits are very large. So I'm interested to see what people think about our approach. Let me tell you about some caveats. The big caveat here is that substantive everyday decisions like I'm talking about, like lung cancer screening, are different qualitatively than major decisions. For high stakes decisions like major surgery, starting chemotherapy for a new diagnosis of cancer, everything that Dan does, which is on way in a different extreme, like LVADs, a neutral, no recommendation approach, the very powerful full shared decision-making model that takes more time, seems completely justifiable if the decision is preference sensitive, because patients and clinicians are willing to spend much more time on those very difficult major decisions, very high stakes. But on the other hand, a neutral approach, that powerful full shared decision-making approach really is not feasible for these types of decisions. Again, because of the time, the fact that they come up very frequently, even with the same patient, we think that trying to take it out of the PCP or the clinician's hands is also going to face tremendous challenges and maybe not be very feasible, because we think payers are going to be unlikely to pay non-PCP members of the primary care team to undertake these sorts of tasks. And we're also skeptical and concerned about patients' willingness to repeatedly engage in full shared decision making, because it can be taxing for these unfamiliar decisions, and they may not be willing to spend the time and effort on it for these types of decisions when they feel fine. A lot of these are preventive services and so forth. Where are the numbers? So we believe, with our approach, we're saying that clinicians and patients shouldn't be burdened with trying to talk about quantitative information routinely, because there simply isn't time in the system, and patients have great difficulty. I've tried this a lot. Patients have great difficulty processing numbers. We do have better methods of doing it, but it's very difficult, especially when time is limited. However, we do agree with shared decision-making advocates that patients should have access to high-quality information if they want that quantitative information. And I think we need to do a lot as a medical profession to try to make that kind of information available to patients that desire it. But it is going to be a minority of patients. Is this just paternalism in disguise, especially that strong recommendation at the end? We're explicitly designing this approach to be not at all about telling the patient what to do. It's about how to make that initial recommendation based on the degree of benefit. With this approach, we're rejecting unchecked paternalism, and we're rejecting the idea that clinicians should be passive suppliers of probabilities, information, quantitative information only. We think that good clinicians should make a personalized recommendation and happily support the patient if they decline that recommendation. They support the patient in making the final decision. We don't feel bad as clinicians when we make a very strong recommendation to a patient we feel is an ideal candidate for lung cancer screening, and we accept it if they decline that recommendation. Both of those things can happen. How do you identify that preference-sensitive zone? What's that process look like? One of the nice things about this preference-sensitive concept, including that preference-sensitive zone between don't recommend and recommend, is that it really dramatically decreases the stakes of setting thresholds compared to our current bright line. That's the difference between getting screened and not getting screened. This approach can really decrease how controversial those decisions can be. We've had a lot of interest and success using simulation analyses, microsimulation, that can really comprehensively put all of the important factors together, but pros, cons, preferences, to try to get us some sense about where that preference-sensitive zone might be. We think that can be very helpful, and this is what we did in our Analyses study that we published last summer. But the best process for setting that preference-sensitive zone, distinguishing between the red zone, the green zone, and everything else in between, is still very much an open question. I'd be very interested in your thoughts on that. To the extent to which we should include individual clinicians, expert panels making this decision, how should we include patients in that? How should we incorporate this modeling approach? All of those are still open questions, and something I'm actively studying in my VA Career Development Award. What's new about this approach? With this approach, we're really trying to move past providing quantitative information and really focus more on how the recommendation is made, trying to improve the way that the recommendation is made, and trying to get clinicians access to the information that they need to base that recommendation on the degree of benefit, or the best evidence that we have for that individual patient. With this approach, we're also trying to explicitly acknowledge the fact that the benefit exists on a spectrum, which is just a reality with clinical medicine, and that there's going to be often a preference-sensitive zone. Our approach focuses on feasibility because we need an efficient process. We think it's doable, and it's systematic and concrete. In addition to that, we've designed the approach specifically to meet the principles of shared decision-making And looking at the larger literature, which is very vast on this topic, we've designed it explicitly to meet the transparency standard of informed consent previously articulated by Howard Brody. So in conclusion, PCPs need a way to make these substantive everyday decisions more patient-centered than what we have now. We think that substantial progress can be made toward personalizing these decisions if we give clinicians individualized estimates of benefit, including clarity about where that preference-sensitive zone is for their patients, so they can quickly grasp onto what's most valuable for their patients and avoid the ants and pounce on those valuable pigeons. And we think that they would be open to a more patient-centered process, like targeted brief shared decision-making as I've described it, if they feel it's feasible for them. We think that our process it's not only feasible, because this is something that I do in clinical practice, and it's definitely feasible. We also feel that it can help clinicians be skilled health advocates for their patients, because it can help clinicians communicate across this entire spectrum of benefit, from low benefit to preference sensitive to high benefit. I've thought about the degree of benefit for you specifically as my individual patient, and here's what it is for you. And we think that is a really important thing to do for our patients, to kind of foster the principle of patient-centered care. And also I've seen that it can strengthen the patient-clinician relationship, especially in that preference-sensitive zone where I'm taking the opportunity and the time to say, this isn't a clear-cut decision, and I want to engage you a little bit more. That has some benefits as well in terms of the patient-clinician benefit relationship. From our clinical experience in reviewing this very large medical literature on this topic, we feel that most patients deeply desire, and also deserve that their doctors care for them as individual patients. They want typically information, they want a recommendation, and they want no-fault veto power. And they're fine with us being gentle, skilled health advocates, as long as we fully respect their autonomy to make the final decision. So I've talked about the goshawk as kind of my metaphor for this idea of clinicians as noble graspers, quickly grasping on what's the most valuable action they can take for their patient, but noble in their approach to making recommendations, skilled, so that they're not just constantly telling patients what to do. And I'll come back and close with the hawk. So the hawk is known as being a fiercely independent creature, a creature whose defining trait is the capacity to fly away. They're literally symbols of freedom and independence in our culture. This is from a 1931 Harley-Davidson ad where they're trying to tap into that, saying if you ride on a motorcycle, you'll feel as free as a hawk on a wing. And I think this aspect of human nature is really important. None of us like being told what to do. That goes for doctors, that goes for patients. And we really need to make progress on making these sorts of decisions more patient-centered, because they come up a lot. And if we don't move the ball forward and make these things more patient-centered, we'll end up very frequently telling our patients what to do. And they may not like that, and they might just fly away. All right, that's all I got. Thank you for your attention. Yes. Right. Right. Mm-hmm. Right. Yeah. I think so I don't think that this approach is feasible for the totality of, so I totally agree with you, what you're saying. It's not feasible for the totality of these sorts of decisions for an individual researcher, but I think it's feasible for us as a profession to be able to we have this relative risk reduction And if we don't, maybe we should, maybe we shouldn't be recommending it routinely. And we have very often validated prediction models for baseline risk. And a lot of times it's just like for lung cancer screening, actually I can automate this. That information exists in the clinical record, and we have the ability to automate that information. So to the extent that we can automate it, or if we can get it, quick as part of our quick questionnaires for patients to input that information, all of these things are very challenging. But it is possible because I didn't go into this, but the value that you can add with this approach is multi-layered. I think the patient-centeredness aspect is important. Clinicians like it because right now, preventive services, the way we make recommendations, is kind of this separate thing in our clinical care. And a lot of clinicians feel it as very burdensome. But we've seen with this type of approach, it brings it back into this sphere that is kind of enjoyable to provide that kind of care. They feel it's valuable for their patients. And then from a cost and net benefit side of the equation, I think it can add a lot of value there as well. But there are still lots of challenges. I'm going to go with Laura because I like her a little bit better. But to be very honest, I would love if a patient asked that. I don't know if I've had a patient ask that kind of question. But what I've moved toward, I used to try to provide quantitative information up front, and then I was ready to provide it if I got asked that question. But now, if I was asked that question, I would give them qualitative information. I would say, we're talking about a pretty big benefit. I don't say that for a lot of patients, but your risk is much higher, and you have you're pretty healthy still. So I would provide qualitative information, and if they asked to see the numbers, or if I got some sense that they would want that, I have lots of stuff ready to go myself because I like that. But I've had very little success in the clinic setting discussing numbers in a way that doesn't make their eyes glaze over, that they can act on.
So the devil, I think it's great.
Yeah.
Fun to see all the but I think the devil's in the details on some of it.
Yeah.
So there's 2 points I want to raise. Your challenge, I don't know if people know this, but this whole idea of can you make a recommendation to follow your decision? Pretty controversial thing. I tend to agree with you. I actually disagree with you. So the high stakes decision, no recommendation, take patients even there and want some sort of recommendation.
I agree with that.
It should just be sort of based on their value. So I wonder how much pushback you get. So that's one. And then the other, the sort of, what do you call it, the benevolent veto power?
No fault veto power.
No fault veto power. I think clinicians, when they get vetoed, quickly turn from like a goshawk to a chicken with one leg. I think that is like a gigantic barrier to this approach that's kind of hidden in there.
Right.
Is how do you get clinicians sort of have no fault, let the patient have no fault veto power? But I find cardiologists,
Yep.
they're not giving no fault.
It's sometimes hard for me to explain this, but I experienced this transition myself, where I really enjoy the no-fault veto power as a clinician, and it's there because there's this I've built this psychological distinction between my recommendation and the decision they make, and I want to be very clear about how I put everything together for them, but it's like I'm setting something on the table. Here's my recommendation. I'm going to put it there. Let's look at it, but it's separate from me. So when they say no, they're not saying no to me. They're saying no to that thing on the table, and that feels very different. And it feels much less emotional for the clinician if they can separate the recommendation. They're trying to put, and then, but that, I think that is a challenge, and how hard is it going to be to implement that? And then the first part of the question, Oh, I found, so Angie does not like this approach. But outside of that, I've had surprisingly little pushback. She is very concerned about the recommendation, and because she feels that patients are unlikely to go against a recommendation. But I believe that there's a lot of devil in the details there. It's how you give the recommendation. I think one approach is to stop giving recommendations altogether. Another approach is try to improve the way we make recommendations. And in my view of the literature, patients and my clinical experience, they really want recommendations. And so I like this approach myself. Yeah. Right. Right. Yes, that's totally. No doubt about it. I think it meets it in spades. If you look at I have some slides here about what that is, and it's probably hard to read, but it hits the things. It's just more concrete than you typically see. We're talking a very concrete approach that we think is simple enough to be systematic, but it hits the important elements. And in fact, it shares something else in the shared decision-making conversation, which is the recommendation. To me, that's a part of the shared decision-making. It's what the clinician is sharing, their recommendation.
Well, so I was like the last one. Okay. Of course. There's more controlling than I am. So my question is, you made the decision here, and it looks like you have a system that works really well for the patient-centered focus on clinician. You don't directly involve the patient. I'm sure you have some reasons for that. Given the limited time, just kind of talk through pros and cons. And what I didn't hear here, without involving the patient, you didn't get into the patient's values, unless it was really sort of a little bit about the probability of what it is. But again, the little I know about it is kind of, it gives us a whole lot focus on decisioning for the patient and the values.
Right.
But if we could just talk about that, if that's a different type of decision or it's just a different possibility.
Yeah, the values clarification aspect of this is missing. We're really focused, I think that would come up more in the conversation. With this approach, we're just really narrowly focusing on that initial recommendation, the initial approach. A lot of that stuff comes in later. And I think the values clarification actually is really enhanced by this approach because the patient, these are typically totally unfamiliar decisions for the patient. They've not thought about it at all. And many patients don't care to think about it a lot. They find this very dry and uninteresting. They'd like to go carry on. So if they have a recommendation that's clear, like what we're talking about, they have more of an opportunity to factor that into their values. What does my doctor think about it? Right. Yeah. It's I think it's not the same as a lot of the values clarification stuff, right? But it is in there because values are much more important for that, by definition, for that decision. But I think if you were to get into, I'm concerned, I don't know what the right answer is, but I'm concerned that if you get into those traditional exercises, you're now taking it outside of the clinic visit in time. Yeah.
So this is the last patient-centered decisions seminar series, and a wonderful one to wrap up. And my question / comment is, it seems like so much of this has to do with the mindset that you approach the conversation. To be truly patient-centered and following the it's not necessarily about whether you're making a recommendation or not. That it's about and whether someone's expecting your recommendation. It's this mindset that I'm trying to do what's best for you as the patient, truly patient-centered for you. And that's a different mindset than I can imagine someone my recommendations to be seen as right, appropriate for everyone. And so how do you distinguish that mindset? How do you encourage clinicians to adopt more of that patient-centered mindset than the right mindset?
I think showing them how these things vary, and you have this chance of benefit varies from very small to very high. Clinicians tend to get it, that at some point it becomes pretty clear that this is important for the patient. At some point it seems like not a great idea. And then like there's this huge area in between. It's like it becomes obvious to people that it's not super clear what the right thing is. So just showing them that type of information, I think, is very helpful. Showing clinicians that. Yeah. All right. Thank you, guys.